My name is Paul Gaudin. I'm Chief Executive and founder of carerooms.com and also a serial investor in medtech services. So I got a view of a number of different parts of the current COVID crisis and the longevity process from beginning to end. Over the last 8 weeks, we've been involved in setting up a whole range of different facilities, and we are seeing the planning now for the next phase of both the COVID wave as well as elective surgery. This slide shows where we are at the moment, but also the impending backlog of NHS and chronic and critical patients who are afraid of going into hospital, which will then collide with wave 2, which is likely to happen around about August. And then, of course, we enter into the flu season. So in terms of 4 streams flowing into one river, we're actually looking at a complete flood this winter. So it's important that right now what we do is plan strategically for that, of course, learn the lessons we have over the last 8 weeks, and not to become complacent on the fact that we built the Nightingale centres to produce capacity, but that capacity may well be needed in a different model. The postponed elective surgery bubble is showing that we are now, with new procedures and new disciplines and protocols that are being introduced, we're looking at oncology patients having to isolate for 14 days prior to surgery to ensure that they're not infected. But what happens after them? And this introduces a significant barrier to ease of flow for oncology patients, of course. And that goes through to endoscopy, general surgery and cardiology, and orthopedics, of course, as well. So with over 7 million people on the waiting list, this is just overwhelming our services yet again. So we've got to have a whole system approach, a completely different look at the way we manage and look at our services. We're expecting to need 3,200 community beds, and that's just for the COVID-19 rehab. That's nearly 1 in 4 of all community beds. So this needs a whole system approach to the problem, not just a hospital, not just a care home, not just a domiciliary care. We've got to look at this completely differently. Key drivers that are affecting our care system are the C-19 unpredictability. We really don't know yet what is going to happen. We're seeing patterns coming back from China, of course, and Asia, where they were the first ones, and we're beginning to see that second wave approaching. We've got massive fear, particularly amongst our older population. We've got infection control, which is better or worse in different environments. We've got the affordability, both at a consumer level, but significantly at a macroeconomic level and on behalf of governments. And then we've got accessibility of services, which quite frankly is becoming more and more difficult. We did see, of course, a lull over the last few weeks in hospitals and in primary care as well, where we've seen a really unusual time when people are just free of capacity. They've got the consumers are becoming used to using technology and remote video consultations. So this has been very good from a medtech perspective, and allowed patients who would otherwise be very isolated from medical services to engage with them. Then we have a capacity issue, and this goes for both National Health Service and national programs around the world, but also the capacity of care and what happens next. And then, of course, the longevity issue plays into this. People are living older for longer, but not necessarily well. A terrible statistic, and it's a terrible indictment that will follow us for a significant period of time beyond this last 8 weeks, was that the NHS cleared the equivalent of 52 hospitals of patients to get ready for this pandemic wave, but they cleared them without testing them for COVID into the communities and into care homes. We're now seeing an incredible level of deaths in that environment, and that's going to be a legacy that's going to impair patient flow, impair confidence in that sector, and impair their ability to perform. And a recent survey this last week showed that over 40% of care homes believe they won't be in business for much more than the next 3 to 6 months. So we're going to see a crisis in care capacity. These carers have been heroic. They're underpaid and under-resourced with PPE, and I've been involved in situations where we have tried to provide PPE through various other channels, but they've been consumed by the National Health Service. So rather than treating the care industry as a partner in this, they have been seen as the poor partner and disconnected. And again, we have to think differently. We have to come together. I've been involved in repurposing aircraft to try and create a stable freight channel, cost channel and supply channel of PPE from around the world. As we've seen a massive reduction and constraint in passenger aircraft flow for all the obvious reasons, we've seen a huge increase in the cost of air freight. So what we're doing is buying redundant aircraft, wide-bodied, turning them into freight aircraft, stabilizing the air freight marketplace and the pricing and the supply chain, and indeed the funding is a very important part of this to maintain both confidence in supply, confidence in quality, and cash flow to fund all of that between the manufacturer and the NHS and our care system. The hotel sectors, we've been involved in repurposing hotels to turn them into short-term facilities, either for step up, step down, hot and cold as well. And more than 7,000 nurses have come back to work. They've re-registered. So by engaging that amazing resource and repurposing much of it, we have the potential to do this for the longer term rather than just for this COVID wave. So what needs to change in our care system? We need a public health sector willing and able to partner. Our experience is that each partnership, each channel, each vertical, each component of the system thinks and acts individually and independently. We have seen an amazing opportunity and amazing behaviours, and which have been both refreshing as well as concerning, where organisations have come together for the first time to work to the good of the country to fight this COVID crisis. Central government investment has been overwhelmingly positive, but lacks the time in order to focus that investment for the most positive impact. We need insurance product to cover the care funding gaps. This is where somebody's paying for their own care from a discharge from hospital, but also hasn't got the liquidity. So that's typically a 3-month product. A 3-month period where you can't get funding from an equity release because of the legislative process that one has to go to, which is right and proper. It protects everybody, but there need to be products that can fund that gap so that patients can be safely discharged to places that they've chosen, they want to go to, and the funding and appropriate funding can be given and the appropriate care can be given. Equity release providers with new care bridging loans can be part of that, and mortgage flexibility as well. We are, as care rooms have set up hosts all over the country. We've been able to engage them during this COVID crisis at the end, because at the beginning we locked them down because we weren't sure of the risks that we were placing them under. Now what we're seeing in the way that we can control the COVID environment and can control the risks is that they're all coming back and saying, we want to help, we want to be engaged. Engaging the new volunteer army as well in this whole process of community support. We've got to embrace that, harness it, and use it for the long term, otherwise it will just naturally dissipate. Deploying the NHS returners in the community as well, not just in the hospitals. This is a combined battle against COVID that we need to embrace together. And a new governance and safeguarding process needs to step back and then step forward to understand how it is going to govern properly and safely all these new environments where care is being delivered by new people who haven't delivered it before, those community people, the volunteer army, and how we get training in place to do that properly as well. All of this has to happen now. We can't introduce this in meeting after meeting after meeting process. It has to be done in an agile format, properly, professionally, safely, but now. And then the technology-enabled care connection to the NHS, that needs to be joined up from the patient in a care home straight back to their primary care professionals, straight back to the hospital. There needs to be proper linear connection of care and technology. It's there, it just needs to be deployed in a more responsible fashion. You bring all of these together and you create a new care function and a new care model. Now, Care Rooms for the last 12 to 24 months has been developing its model around building a community that cares of host homes. One could call it Care B&B if you like, but it's effectively the most incredibly powerful model dealing with the psychological impacts of loneliness and social isolation. But also it's now able to boost its infection-controlled environment as a model to support patients who are really concerned about the revolving front door of domiciliary care, or going to a care home where there is obvious an infection risk, or staying in hospital where there is again. Our technology-connected care hub for safeguarding allows us to do this in any environment, not just in the home, but the patient's own home and or care homes or wherever we are setting up an infrastructure to support the current COVID crisis. And then the sharing economy model allows us to keep costs low and shares the income amongst the volunteer sector. So when a patient leaves us and goes home, they become part of that local community, not a socially isolated, lonely individual. And it's all easily accessible online. We're all getting more and more used to the use of technology, the application of the technology, and we've made this available through the NHS Care Capacity Tracker. So discharge teams in any environment can find the nearest local capacity, click and book, and get on with the process of avoiding log jams and blockages in the system. We're able to offer over 2,000 COVID-safe rooms to support the health and social care system at this time of changing needs and increasing demand. But that's infinitely scalable, and we're doing that into the USA as well at the moment. And it works. It fundamentally works at a human level, at a care level, and a clinical safety level. So we're proud to have adopted the model and been embraced into the system over the last 8 weeks. We look forward to how we support Wave 2 and beyond. And we're proud in what we've been able to do with investing in the Carecraft model internationally to repurpose otherwise redundant wide-bodied aircraft, to bring them into that marketplace to stabilise freight costs and to free up that supply chain of COVID support services, technologies, PPE and consumables. Thank you for listening, and I'm available and contactable on the details below. Paul Gaudin. Thank you very much.